Let me change tack for a second and mention another aspect that is emerging in lymphoma that I think is important and interesting, which is, first of all, lymphomas are obviously tumors of the immune system, and so they arise within a context of immunity and protection against disease that is a bit different than other tumor types. And we, with the advanced knowledge of mutations and pathogenesis, we are, for the first time, starting to be able to consider these tumors from the standpoint of, from the whole system that they arise from, as tumors of the immune system itself, which implies that not only the tumor cells are perhaps aberrant, but also the entire immune system is a bit off balance at the same time as it evolves with the tumor. So maybe I'm hoping that, Riccardo, you can comment a bit on how some of these new advances are enabling us to view lymphomas in a more holistic manner, and what that means for understanding pathogenesis, and also from the standpoint of maybe being able to take advantage of that therapeutically.
Okay, so I think you said correctly that lymphomas are fairly unique biologically because, yes, they hit the tissue like many other tumors, but they hit particularly a structure, the germinal center within B cells that has unique properties. As among the properties that it does with the genome things that no other tissue is allowed to do, change actively its genome to allow diversification of the immune response. And so this mechanism to break DNA and mutate DNA, which is physiologically going on in germinal center, is one of the engines that leads to lymphomagenesis in terms of mistakes that can occur. I think the repertoire of damage that this activity of mutational activity of, for instance, of the AID enzyme generates in lymphoma is still poorly understood. And another aspect is that this probably cascade of mutation that physiologically occurs and sometimes is deranged in lymphoma creates probably an equivalent cascade of neoantigens that the organism has to deal with, so immunity against the immune system. So also the lymphoma, at least in the early stages, is born and is dependent on a lot of other cells that normally support the activity of germinal center cells. And probably for a long time during the evolution of lymphoma, particularly follicular lymphoma, the tumors remains dependent on the signals from the environment that are acting physiologically and still create dependency on the tumor. That creates a whole new set of therapeutic targets. Rather than killing the tumors, in a sense, one can think also of depriving the tumor of the feeding sources of the signal that keeps it alive and proliferating. And that's a whole field of tumor microenvironment that is I think one of the new frontiers in oncology. One interesting aspect, I think, is how is the tumor manipulating the microenvironment? And I think there has been relatively little attention to what are the genetic lesions that instruct the microenvironment. There's a lot of attention on which cells are around the tumors, what do they do, what type of immune cells, but who is recruiting those cells? Who is telling those cells? What I think it's the tumor itself probably, and still we go back to the genetics, how the genetic instructs the microenvironment. I think it's a very interesting field.
How do you feel this instructs like your work looking at post-germinal central lymphomas? How do you see that as playing into modeling disease, understanding how to treat?
Well, I think the microenvironment undoubtedly plays a critically important role, and also how the lymphoma cells then silence or activate certain aspects or certain components of the microenvironment for their own survival. And I think modeling it in the mouse has the advantage that you can actually deconstruct that, right? You can activate or inactivate alleles in the microenvironment or in the lymphoma cells, and then really deconstruct that interplay. And I think we've heard it yesterday from many groups. We have new technologies now that allow us to really get a glimpse as to what is this composition of the microenvironment really looking like. And it's easy in the mouse because we can get as much tissue as you want and look at it. You can do it by single-cell sequencing, you can do it by imaging, by imaging mass cytometry and so forth, to get an idea also longitudinally how the microenvironment changes with the evolving tumor, and then trace that back to the mutations that also longitudinally occur in these lesions. I mean, we have prime examples in aggressive lymphomas and Hodgkin's that targeting the microenvironment is therapeutically highly effective. So I'm just talking about PD-1, PD-L1 blockade in this disease. And I'm pretty sure that during the next couple of years we will find the other tumor stroma or tumor microenvironment interactions that we can therapeutically target as well. And I think the mouse can be an informative tool for that purpose.
So given all these novel and amazing technologies that can deconvolute and identify components of the microenvironment, things you mentioned like imaging mass spectrometry and others, how will this greater understanding of what the composition of the microenvironment is impact on classifying the disease, on helping us to refine our diagnosis as to exactly what's going on? So perhaps the mutations are one part of the picture. Another equally important part of the picture is what are the components of the microenvironment that these tumors are living in? I'm wondering if you have some thoughts about that as well.
If we listen to Ash's talk yesterday, it's almost frustrating, right? I mean, we were proud of our 5 clusters in the BCL, and here's like, what, 40 different microenvironmental clusters. You're right. I mean, we will have to take this into consideration, and I'm sure that eventually we will have therapies that are not only based by the tumor intrinsic mutations, but also based on the composition of the microenvironment. But I think we have to understand a lot more of the biology before we can actually say we derive a certain therapy based on the microenvironmental composition. And I think the other thing that's important when you consider DLBCL, I mean, we have a very effective front-end therapy, right? We have R-CHOP or anthracycline-based therapies that cure 60-70% of the patients. So I think we can start with very simple tasks, right? So can we do anything to identify those patients that will fail, right? R-CHOP, and so far we don't really have a very good idea of who these patients really are. So if we could spare them the R-CHOP and give them something other, something more targeted or so, that would, I think, already be a huge leap forward in my view. And I think we have the tools together to do this now. And the other thing is, yes, we have some ideas as to what happens to these tumors once they've seen R-CHOP, and we've heard data on the ICML this year about this. The thing that came up is P53, right? So that's probably not so surprising. I'm sure there will be other things, not only mutations, but also composition of the microenvironment that will be associated with resistance. So if we understood this better, I think we would probably have the ability to deliver more precisely targeted therapies as well. So I think while it's great to think, in these big dimensions of targeted therapy up front, we can do little steps also that will mean a lot for our patients. If we could identify the ADL patient that will not benefit from R-CHOP and we spare that, would be great, I think. So we should think about those things as well.
But I think there must be an opportunity for a completely new knowledge. It's like, say, for example, Ari, you'd comment on this explosion in epigenetics in relationship to these particular tumors. But I say the same explosion is going to happen in relationship to the tumor microenvironment, because we saw yesterday the new tools that are there to look at single cell and deconvolute the different compositions of the tumor microenvironment, but also to kind of do a multi-immuno type approach where you can look at 20 to 30 different antibodies, look at the spatial relationship between individual cells and expression. And I think the notion that AI is going to be important, I think, going forward, whereby we're collecting a large amount of data that no individual can actually visualize and make sense of, but there must be some way of taking that information and identifying new strands and new relationships that probably will explain the types of heterogeneity and oddities that you've probably been seeing, Elias, under the microscope for the last 30 or 40 years, that must hopefully open a door to a way of treating either individual patients or potentially a large gamut of patients with a single disease entity.
I'm glad you mentioned the AI idea. I'm wondering, Elias, what you think about these artificial intelligence approaches that are being applied now to lymphoma, in fact, by multiple groups to try to come up with, to take all this multifactorial information. I mean, will these AIs be the pathologists of the future? Are you seeing now for the first time, the future of how lymphomas are diagnosed? How does the microenvironment aspect play into that?
I think it's a long time that I started to do pathology when we only had two colors to make diagnosis. That was a blue color and a pink color, and with that we did, pathologists did a great job identifying diseases. Since then, with the new wave of technologies, immunohistochemistry, flow cytometry, southern and northern blots, arrays, next generation sequencing, now artificial intelligence, with every single wave, the question was, pathology is going to disappear with this wave? So it's a recurrent question. Well, I think what is happening is pathology is evolving with all these technologies. What is disappearing is the pathologies that do not integrate this knowledge in the clinical practice. But I think is pathology as the science that tries to understand what is happening in the tissues with the goal to make precise diagnosis and predictions, is incorporating all of these technologies and this new perspective. And none better than the pathology knows what are the limitations of the eye by looking at under the microscope, and you know very well where you reach and you don't. And in this sense, definitely I think these technologies will help us to better understand this complex situation. But not only pathologists, I think all the people that are dealing with this, I think the challenge is how we integrate all these different layers of information into making a conceptual idea that make us act. Because all we want to have an information that allows to make decisions regarding the patient. So I think we will have to keep using all the information, including the artificial intelligence.
But the pathologist is the front end. I can see, say, from the LNPP over the years, that with Elaine Jaffe, yourself, Randy Gascoigne, that in a way, as pathologists, because you're seeing the tumor, you're the person accessing the tumor, providing the tumor to the researchers, that you're really the first port of call in that pipeline that you just described. And I think you've guided the community in relationship to the key questions, and always kind of made us very much aware that there's a lot of heterogeneity here, that there isn't a simple diagnosis and a simple answer that maybe sometimes researchers like to think there might be.
Well, I think I always have seen pathology as a bridge between the clinical reality and then the door to go in depth in the. Obviously, nobody can cover the whole field from clinics to the basics. So I think we need this extremely cooperation, and I think that's the way we are, and probably that's why we are better understanding the complex biology. And probably one of the major success in the last 5 years, I would say, is the close relationship between all the players in understanding these tumors, and I think this is the only way to success in terms of understanding this.
Also, we have to remember that, as Elias said, one now can recognize more than 70 types of lymphoid malignancies, right? But how many people in the world can recognize those 70 types? Mm-hmm. The top academic center, the lymphoma specialist, if you go from a lymphoma pathologist to a general pathologist, probably the number of entities that can recognize goes around 10, right? And if you go to a minor hospital in the south of Sicily, probably they still have to deal with BOT. And the majority of the world will not be dealing with artificial intelligence. So the groundwork of the pathologists, which I echo you as being spectacular, doing genetics on lymphoma, I'm always amazed on how what has been seen at the microscope in most cases relates to a distinct genetic entity. So I would say we're far away in 95% of the world from getting rid of pathology. Actually, we need more lymphoma pathology.